Hello and welcome back to the case of the month for the month of November. My name is Amr DeBase. The attending this month is Dr. Hugh Hagen. This month we're presenting bilateral ulnocarpal impaction. I have no disclosures. Our patient BL was initially seen on February 29th. She's a 34-year-old, otherwise healthy right-hand dominant female with atraumatic, dull, aching discomfort on the ulnar aspect of her right wrist. Associated symptoms included snapping and popping on flexion and extension of her wrist. She had tried splinting, topical Voltaren, and Emetral dose pack without relief. The patient is a non-smoker and she works as a nurse. A focused physical exam demonstrated mild swelling over the distal ulna dorsally on her right wrist as compared to the left. She had guarding, a negative ECU synergy sign, and no tenderness along her ECU tendon. Her left wrist was negative to non-tender to palpation. Her right wrist had moderate tenderness to palpation dorsally over the TFCC and exquisite tenderness notably to the ulnar fovea. She had extreme discomfort with ulnar deviation, particularly if this was combined with flexion and extension. X-rays of her wrist were taken that demonstrated approximately 4 millimeters of ulnar positive variance, with cystic changes on the ulnar aspect of her lunate and capitate, as well as a calcification just distal to her ulnar styloid. An MRI was obtained of her right wrist that demonstrated ulnar abutment with TFCC central tearing and edema within the ulnar body of the lunate and the proximal portion of the triquetrum. Notably, there was a synovial cyst volar, and again, pressure changes within the ulnar lunate, proximal triquetrum, and proximal ulnar aspect of the capitate. Here you can see the coronal slices. Motion artifact, yes, in these sagittal slices, but you can still see the aforementioned findings, particularly in the lunate and that synovial cyst. Here are the axial cuts. So for our assessment, this is a patient with ulnocarpal impaction, central TFCC partial thickness tearing, and a large synovial cyst. The plan was wrist arthroscopy, debridement versus repair of the TFCC, and an ulnar shortening osteotomy. Interim history includes prior to surgery on her right wrist, patient was seen at urgent care after a mechanical ground level fall. She sustained a left wrist injury after falling on her outstretched hand. Her exam was relatively unremarkable, and she was given outpatient hand surgery follow-up. However, x-rays of the left demonstrated 3 millimeters of ulnar positive variance and osteopenia and cystic changes to the lunate consistent with ulnar abutment as she had on the contralateral side that she was initially complaining of. Because she had just injured her left wrist, the decision was made to treat this non-operatively at that time and focus instead on the right wrist. Intraoperatively in the right wrist, there was complete loss of cartilage down to subchondral bone in the wrist arthroscopy portion of the case. On the ulnar corner of the lunate, there was slight separation of the LT joint. There was a partial thickness central tear of the TFCC and fraying of the volar ligaments. A shaver was inserted and all of the loose frayed tissue on the TFCC was removed, and the edges of the cartilage on the proximal lunate were smoothed off. The midcarpal joint demonstrated some LT joint laxity. The wrist arthroscopy portion of the case was then completed, and the ulnar shortening osteotomy portion of the case was begun outside of the wrist arthroscopy. A 5 millimeter oblique osteotomy was performed, and fixation was done with a Synthes 8-hole LCP plate for neutralization. In the interim, the patient progressed uneventfully over 3 months on the right wrist. However, for the left wrist, which she injured and was seen at urgent care for, she had notable tenderness to palpation to her ulnar fovea, dorsal TFCC without any DRUJ instability, and thus an MRI was ordered. The MRI on this side was very similar to the initial MRI for the contralateral side. She had cystic changes consistent with ulnocarpal impaction and full thickness tearing of the TFCC and a loose body between the ulna and the pisiform. You can see here on the coronal cuts as well as the sagittal cuts here. And again, the axial cuts very similar to the contralateral side. So for her second assessment plan, very similar to prior, she had ulnocarpal impaction, central TFCC partial thickness tearing, and a large synovial cyst. So the plan was, again, a wrist arthroscopy, debridement versus repair of the TFCC, and an ulnar shortening osteotomy. Almost identically to the contralateral side that was done initially, the patient had fraying over TFCC that was debrided, and the cartilage damage and fraying was also debrided. After the wrist arthroscopy portion of the case, an osteotomy was done with a 5mm oblique cut, and again, a Synthes 8-hole plate was used for neutralization. Patient was last seen in the last month, and her right wrist is now pain-free, which was the side done initially. She has appropriate recovery for her left with some mild overuse pain secondary to early return to activity, specifically playing golf. She's otherwise doing very well and is happy with both procedures. Here are her most recent x-rays of bilateral forearms demonstrating appropriate plate placement and successful ulnar shortening osteotomies bilaterally. Thank you very much for watching, and we'll see you in the next one.